All right, good morning. Good morning. So this morning for our grand rounds, we have Dr. Verghese, right? Excellent. With us today from orthopedic trauma. She got her master's of physical therapy at University of Sciences in Philadelphia and got her doctor of physical therapy at Temple. She is here to discuss concussion diagnosis and management with us. So you're in for a great talk. Hand it over to her.
Hello, I hope everybody's happier to be here than in the room next door where we'll be talking about poopite, as Stephen put it. But it would have been an interesting lecture, and I would have been there myself if it weren't for the fact that I'm here. But anyway, so concussion management is a very broad, multimodal area with multiple disciplines, so it's really not possible to do full justice within the hour. But what I've chosen to do is pick a few objectives to enhance our understanding of concussion management and introduce some new elements as they might apply to the acute setting, since I'm a little biased to that area. But most of the studies that we've looked through have been from the athletic population and outpatients. We are now finding the research shows that it can be extrapolated to the inpatient populations with recreational sports injuries, motor vehicle accidents, etc. So that's my disclaimer. So our objectives today are to describe the pathophysiology of concussion, understand the factors that affect outcomes post-concussion, recognize symptoms associated with common clinical subtypes, identify potential management strategies, understand the role of balance, vestibular, and oculomotor screening. Concussed patients may identify with this cartoon. Patients may report a concussion as getting dinged or bumped in the head. They may describe it as seeing stars, feeling dazed or foggy. But clinicians know it's a traumatic brain injury, a complex pathophysiologic process affecting the brain. This type of brain injury may be the result of a direct or indirect impact to the head, but it is always characterized by an immediate and transient alteration in normal brain function. There are two types of biomechanical forces involved in concussions: linear forces and rotational forces. Linear forces create acceleration-deceleration injuries, the kind that you might see in a front-end car collision or in an impact sport. So here, what's happening is the impact abruptly stops the forward momentum of the head, but the brain within the head keeps moving, collides with the inside of the skull, then recoils and impacts the opposite surface, creating a coup-contre-coup injury. These tend to be focal injuries created by the tensile pulling apart and compressive forces sustained during the initial and the recoil impact. In rotational force or angular acceleration injuries, like the kind you would see in a cross-punch injury in boxing, the brain spins on its axis. There are diffuse shearing forces that occur deep in the brain, causing axonal injury. And because of the extent of mechanical deformation, these may be more significant brain injuries. Basic science research gives us some insight into the pathophysiology of concussions. Most of the research at the neuronal level is done on rats, and extrapolating from that, we know that concussion is a metabolic rather than a structural injury. Looking at the level of the axon, the biomechanical force causes a stretching of the axon. This deformation of the axon is setting off a neurometabolic cascade. Intracellular mechanisms are disrupted, membrane permeability changes, and the stretching causes calcium to leak out of to move into the cell while potassium leaks out of the cell. This disrupts homeostasis. This metabolic change causes the cells to work much harder. The mitochondria have to work harder to produce energy. There is what we call an energy crisis. You don't see this acutely on traditional testing, but conduction signals for cell-to-cell communication are affected. The neurochemical abnormalities are present even in asymptomatic patients with normal radiology images. As with any brain injury, cerebral blood flow is diminished. Neurons are in a vulnerable state. The concussed brain cells are more vulnerable for an undefined period of time, during which a repeated insult, even from a lesser force, often results in re-injury, potential irreversible damage, and death. So in a study done on rats, they saw that there was a 10% mortality after a second mild insult at 3 days post-initial injury. In other words, concussion from a second mild impact now presents as a severe TBI. So what's the significance if this were to be applied to humans? Recent literature suggests that the time for physiologic recovery may outlast the time for clinical recovery, and a possible consequence is the additional risk involved in returning to play while there is ongoing brain dysfunction. So there is a need for early identification to provide adequate rest and interventions to protect and prevent re-injury. And this would be especially relevant not just in the sports populations, but also in the community-dwelling false risk population, the recreational sports, and work injury population. Second impact syndrome is a very serious consequence of repeated concussion sustained while still symptomatic and recovering from a first concussion. It's seen in young people. It's very rare, life-threatening, with a mortality rate of 50% and a morbidity of nearly 100% in survivors. In the period between 1980 and 2009, 17 high school fatalities were attributed to second impact syndrome. The pictures you see are those of football and rugby teenage fatalities and survivors. The pathophysiology is that with the second concussion, there is a loss of autoregulation of cerebral blood flow. The result is a rapid onset of cerebral vascular swelling, increasing intracranial pressure, and brainstem herniation failure follows rapidly within the 2 to 5 minutes. This is what second impact syndrome looks like on imaging. The top left image is that of a head CT. The arrows you see point to thin bilateral subdural hematomas. The top right image is an MR image, and the arrows are pointing to the downward descent of midline structures. And the bottom images are that of MR images. The arrows are pointing to thalamic injury. Multiple concussions have been associated with chronic traumatic encephalopathy, also known as CTE. CTE goes by different names: dementia pugilistica, punch-drunk syndrome. It was first observed in boxers, most famously Muhammad Ali. It was thought to be a result from repeated concussive and subconcussive hits to the head. However, current research shows a cause and effect relationship has not been demonstrated between CTE and sports concussions. CTE is a neuropathologically distinctive progressive deterioration of the brain. The pathology has to do with the accumulation of tau protein. In the picture on the right, you can see a normal brain section and one with advanced CTE. CTE starts insidiously as isolated hotspots of tangled tau protein in the cortex. As the disease progresses, the tau migrates. The tangled hotspots blend with each other, and it affects learning, memory, decision-making, and emotions, mimicking dementia. CTE is well known and talked about. However, the difficulty is that we are unable to diagnose this in vivo. The current literature, as we said, comprises of case reports. There's a lot we do not know, like how it relates to concussion in the context of comorbidities, genetic predisposition, drug and alcohol abuse. These slides show whole brain and microscopic sections. The two slides on the left are those of a normal controlled subject showing no tau protein deposition. The two slides on the right are those of a 73-year-old world champion boxer with severe dementia. Very severe tau protein deposition in the amygdala and thalamus. And the middle two slides are those of John Grimsley, former linebacker for Houston Oilers and Miami Dolphins, who died at the age of 45. He had significant tau protein deposition in the amygdala and the adjacent temporal cortex. Recovery from concussion has been mostly studied on young adult male athletes, but the recovery trends do seem to bear out in other populations as well. 40% recover in the first week, 60% by week 2, 80% by week 3. However, a miserable minority of 10 to 20% have persistent concussive deficits and are diagnosed with post-concussive syndrome. But there's a lack of consensus regarding when to term it as post-concussive syndrome or what symptoms to include in PCS. If you compare the ICD-10 and the DSM-4 criteria, there is agreement on headache, dizziness, fatigue, irritability, sleep problems. But the ICD-10 includes cognitive difficulties with concentration and memory, as well as with emotion, stress, and alcohol. Also, their timeline for diagnosis symptoms is more than 4 weeks, whereas the DSM-4 criteria for diagnosis includes mood disorders like anxiety, depression, personality changes, and apathy, and their timeline is symptoms persisting more than 3 months. So what does the research show us on factors that affect outcomes post-concussion? Age. Don't know for sure what the influence of age is. In some studies on sports-related concussions, it shows younger patients have a more protracted recovery. And this may be related to the fact that their brains are still developing. Studies show that high school athletes on average take 7 to 14 days to recover. College athletes take less, on average 2 to 7 days, and professional athletes may recover fully in a day, in maybe even a day. However, in ER-driven studies, younger patients have a better outcome than older age groups, and that may be related to the comorbidities in the older group that may factor into healing. When it comes to gender, the studies consistently show that the odds are stacked against females, whether it's from the standpoint of risk or outcomes. In sports like soccer, baseball, softball, females are injured at nearly double the rate compared to males. Studies are also showing that females present with more symptoms, greater neurocognitive decline, and are at greater risk for poor outcome after MTBI. Repetitive concussion. This was studied in athletes, and the research shows that athletes with 3 or more concussions are at greater risk for future concussions, subjective symptoms, and poorer cognitive performance. These studies were from several years ago, so we don't know if the current concussion management better mitigates this risk with safer guidelines for return to activity. Migraine. Athletes with post-traumatic migraines have significantly lower cognitive performance and worse symptom profiles compared to those with no headache or those with non-migrainous headache. There is a study that compared impact visual memory scores between 3 groups, those with no headache, headache, and non-migrainous headache, and migrainous headache. And what it showed was that at week 1 post-injury, the migrainous group performed poorest in comparison to their respective baselines. Also, in week 2, the recovery was still far from baseline, whereas the other 2 groups were at or almost at baseline. Mood disorders. Several studies have shown that the presence of mood disorders like anxiety or depression is associated with worse outcomes following concussion. Also, if you have a mood disorder post-concussion, it has a negative prognosis for recovery. Learning disability. A study showed the presence of ADHD may be associated with greater risk for concussion. Also, in another study, patients with a learning disability had a more protracted recovery following MTBI. The on-field factors affecting outcomes are amnesia and dizziness. The presence of amnesia is predictive of the ability to recover quickly in less than 3 days. Athletes experiencing a high degree of symptoms and deficits were 10 times more likely to have had retrograde amnesia, and they were 4 times more likely to have had, or they were 4 times more likely to have had anterograde amnesia. So your history is important. Dizziness. In a study with 87 football players, 13 on-field signs and symptoms were looked at, including loss of consciousness, amnesia, confusion, headache, dizziness, vomiting, vision problems, light and sound sensitivity. And it turned out that dizziness was the only factor associated with prolonged recovery. Athletes with on-site dizziness were 6 times more likely to take at least 3 weeks to recover. With regards to neurocognitive testing, athletes with deficits in 3 out of 4 global areas on the IMPACT neurocognitive test were more likely to require at least 10 days to recover. Also, early deficits, less than 3 days, in reaction time and visual memory were predictive of a more than 10-day recovery course. Another study looked at post-injury factors related to outcome. It used the IMPACT post-concussion symptom scale at 3 days post-injury to identify protracted recovery. The patients check, it's a self-reported scale, so patients check off symptom severity 1 through 6, minor to severe, on a laundry list of symptoms. And the top 11 symptom predictors of protracted recovery are noted here in descending order. You can see the dizziness is right at the top, and cognitive, balance, and visual issues are on the list as well. So, concussion is a complex physiologic or functional injury involving chemical alterations in the brain. Conventional CTs and MRIs are not sensitive in detecting concussions. They're used to detect anatomic changes like fractures, hemorrhages, contusions, or edema. In a study, only 3 to 10% of CTs were positive in MTBI. Likewise, in another study, MRI was positive in only 10 to 57% of cases. Advanced neuroimaging studies do show changes between concussed and control groups, but they often provide inconsistent and disparate findings. They also don't show when a concussion has occurred or when healing has occurred. So concussion is a clinical diagnosis done with on-field sideline and acute symptom assessments, neurocognitive tests, balance tests, vestibular and ocular tests. Once a concussion has been diagnosed, it's critical to remove and/or protect the person from situations that might risk a second injury. There is limited empirical evidence on the effectiveness of prescribed physical and cognitive rest. No multi-site randomized controlled trials on prescribed rest after concussion. In fact, strict bed rest, stimulus deprivation, cocoon therapy is not indicated and may have detrimental effects like social isolation, anxiety, physical deconditioning. And it's not an appropriate strategy for all patients. So the priority in the early 24 to 48 hours post-concussion is rest, but not bed rest. Instead, low stimulus activities and adequate rest intervals. So you avoid high stimulus environments like malls, the cafeteria, limit reading, computer, TV texting, and video games. You want to educate patients and their families on symptoms, what to look out for, how to manage the symptoms, and when to seek help. A simple activity guideline for patients and their families is to limit activity if it increases their symptoms more than 2 points on a 10-point scale. And then you would treat symptoms with medications as necessary. Sleep alterations can be a significant issue with this population, and this may be the place to start in symptom management since it has the most potential to affect other domains. It can provoke other issues like migraine, fatigue, depressed mood, and cognitive function. Patients may report being drop-dead tired, laying for hours before falling asleep, waking multiple times during the night, feeling somnolent or unrested during the day. Treatment starts with behavior management. Strive to get 7 to 9 hours of sleep at night. Avoid daytime naps, caffeine after 3 p.m., no phones, blue light, iPad, computers, TV near bedtime, and keep the room cool. Some people may need more than behavior management. Melatonin is natural and over-the-counter, so parents of children may be more willing to try this. Antidepressants like amitriptyline and trazodone may be prescribed. Non-benzos may be helpful for a short period of time to get the sleep rhythm going. And antihistamines may be helpful for a short period of time as well. Keep in mind, though, that medication-induced headaches are quite common, 18 to 25% incidence of patients with chronic post-traumatic headache. Prolonged use of over-the-counter medications, opioids, triptans, can cause a rebound headache. And by prolonged, what I mean is if you need more than 2 over-the-counter medications per week, then you need to consider switching to prescription medications. A concussion may affect any or many areas of the brain, so a comprehensive assessment needs to be done with multidisciplinary tools. Patients need to be serially followed to monitor signs and symptoms and return to activity. This is perhaps better managed in the sports populations and the military, where there has been a lot of research, media attention, and education at all levels. However, concussion also results from falls, recreational activities, motor vehicle accidents, and work injuries. And the reality is that concussion affects a lot of people. 1/4 to 500,000 people each year has some morbidity related to concussion. That's a lot of time spent out of school, work, lost productivity, and a compromised quality of life. In the ED and hospital, screening of different domains is a quick way to assess for deficits and should be performed for early identification and referral for appropriate intervention. It's well established that concussions can significantly affect cognitive function and balance in the first 24 to 72 hours post-injury. Identification and intervention involves a multidisciplinary collaborative approach, including doctors, therapists, athletic trainers, psychologists, and school personnel and work supervisors as appropriate. A helpful way of assessing concussions is organizing them into subtypes as they present clinically and then directing treatment accordingly. So in the next section, we are going to briefly look at different clinical subtypes and how they can be managed. Any or all of these subtypes can be present in a patient. Usually it's a combination, in which case you pick the most dominating subtype and work through that first. The cognitive subtype is most often seen in the early phase. Symptoms include a pervasive fatigue, and this is not the same as having a rough day at work. The fatigue relates to the energy crisis from the neurometabolic cascade. The person starts the day feeling good, the symptoms become more prominent as the day wears on, and worse if there is inadequate sleep. They may complain of a generalized headache or be more distractible at work. Neurocognitive testing will show mild deficits globally, but these deficits have to do more with information retrieval than information coding. These patients simply have a hard time putting it all together because of their cognitive fatigue. The treatment for this subtype includes allowing for adequate physical and cognitive rest through the day, but not sleep. You want to ensure a good night's sleep, but maintain the circadian rhythm as much as possible. Suggest structured rest breaks through the day by setting an alarm or just getting up periodically to walk, change activity, or get some downtime. Sometimes behavioral interventions may be insufficient and neurostimulants may be prescribed, as well as a sleep aid. Studies have been done on the efficacy of neurostimulants, and amantadine has been shown to improve symptoms, verbal memory, and reaction time. For chronic symptoms that linger for months, cognitive therapy may be helpful to develop adaptive strategies. A carefully monitored progressive return to activity is encouraged. The preferred mode is to maintain people in their activities as much as possible, even if it is with adaptations and accommodations, so as to minimize their routine disruption, isolation, and mood issues. And if you do take people out of their routine, it should be for a very finite period of time. The risk factors for the visual ocular subtype include any personal or family history of ocular dysfunction, like a lazy eye, strabismus, eye muscle surgery, or reading glasses. These patients will typically present with a frontal headache brought on by reading or vision related to work. They will describe pressure behind their eyes, will have blurry vision or double vision or vision focus issues like tracking. So these patients are having difficulty with encoding information as a result of their impaired vision, And as a result, neurocognitive testing will reveal deficits in visual memory and reaction time. The vestibular ocular motor screen may reveal pursuits, saccades, and convergence issues. There is very good evidence on the treatment of deficits. If the symptoms are mild to moderate, vestibular therapists are trained and experienced to handle care. But in moderate to severe cases or in complicated cases not responding to vestibular therapy, behavioral optometry and formal vision therapy is indicated. Also, if it's a focal vision convergence issue, return to physical exertion is well tolerated and even welcomed because it helps the patient to feel more normal. The hallmark symptom of the vestibular subtype is dizziness, and it may be accompanied by motion sensitivity and nausea. Patients may report feeling off balance and dizzy with movement, and they may be overwhelmed in visually challenging environments like supermarkets and crowded malls. Computerized neurocognitive tests and vestibular ocular screens will be positive for symptoms. The vestibular subtype typically does not exist in isolation. They can coexist with migraines and anxiety, and possibly because these are shared pathways and hyperstimulating one system is going to trigger the others. Vestibular therapy is the mainstay of the subtype. BPPV will be treated, balance training must be provided, VOR impairments and visual motion sensitivity have certain training paradigms. Also, in the active or athletic populations, as you progress and symptoms improve, you have to start adding high-level dynamic balance and cardiovascular training so as to take it to the next level and eventually to full recovery. Pharmacological management is called for if there are other symptom overlays. So SSRIs for mood, very low dose clonazepam for anxiety, tricyclics for mood and sleep, melatonin for sleep. The anxiety subtype is often seen in high-performing, overachieving personalities. Few people will see themselves as anxious, so you really need to carefully probe with questions like, do you have difficulty turning off your thoughts? Do you feel overwhelmed? Have your social activities been restricted? Neurocognitive testing for these patients, vestibular ocular screens, are going to be normal. In this subtype, you want to regulate their schedule right away. Address their sleep, exercise, diet, hydration, and stress. If they have vestibular and migraine comorbidities, that should be treated first. And once the vestibular component resolves, push them in exertion therapy. Exertion therapy has good outcomes, especially in athletes. And if necessary, you want to provide psychotherapy and pharmacologic treatment. Migraine is a neurovascular event involving abnormal activation of the trigeminal vascular system. It is more than just a headache. Other possible symptoms include dizziness, nausea, vomiting, light sound sensitivity, eye pain, and neck pain. Persons may suffer from a sleep disorder, stress, and anxiety. Auras are transient neurologic symptoms lasting less than 60 minutes. They're present in up to 1/3 of migraines. There are different types. Visual is the most common in over 90%, but you can also have sensory, language, and motor auras. The presence of an aura confirms the diagnosis of migraine. Risk factors include personal or a family history. There is a genetic component to migraines, and migraine susceptibility is increased after a concussion. Other factors will include vestibular disorder, motion sensitivity, and anxiety. Managing migraines involves a multimodal approach. Behavioral modifications would be to regulate sleep, decrease caffeine intake gradually, avoid dietary triggers like cheese, red wine, and aged cheeses and red wine. And stress is a known trigger for migraines. Sometimes medications are necessary. There are two classes. The abortive rescue medications is what you would take when the migraine has already started. And in this category would be things like Excedrin migraine and triptans like Imitrex. Preventative medications are considered for more frequent migraines, And in this category are antidepressants like the SSRIs and the tricyclics. And anticonvulsants also like Depakote and gabapentin, and Topamax is the most common one. Supplements are also used in migraine management. Magnesium oxide and vitamin B2 have been shown to have good efficacy in the prevention of headaches. Cervical symptoms include neck stiffness, soreness, pain radiating upward into a headache, and pain that is aggravated by posture and neck movements. Risk factors would include a prior history of neck injury, high velocity trauma, and rotational impacts. In this subtype, neurocognitive, vestibular, and oculomotor screens are going to be normal. Management includes imaging to rule out fractures. Cervical symptoms and cervical headaches are managed with physical therapy, TENS, acupuncture, massage, trigger point injections, occipital blocks, you know the works. So far in this presentation, we've defined and described concussions, suggested organizing them into subtypes as they present clinically, and looked at potential management strategies for concussion. Traditionally, neurocognitive testing has been the mainstay of concussion management and falls within the domain of neuropsychologists and neurologists. So in this last segment, we're going to briefly look at the role of physical therapy in identifying balance, vestibular, and ocular deficits, and suggest screening that might be effective for triaging patients towards early intervention. Why do we need this? Balance, vestibular, and ocular oculomotor deficits have a high prevalence post-concussion. If you look at some studies, dizziness is present in 23 to 81% of cases in the first days post-concussion. Studies in athletes have shown post-concussive balance problems in nearly 40%, especially when you alter the visual conditions or the support surface. Oculomotor issues are seen in up to 61% of vestibular problems in up to 34%. In a study done on military personnel, dizziness is the most common symptom post-injury in blast-related MTBI. Oculomotor impairments are seen in up to 65%. Up to 32.5% have dizziness that prevail at 5 years. Dizziness is often indicative of vestibular or oculomotor dysfunction. It's important to clinically screen for these and not just rely on subjective reporting. Athletes are notorious for underreporting their symptoms or sometimes just magnifying them even. The adult working population may be also guided by personal motives in how they report their symptoms. So early identification and referral for intervention is critical in symptom management, preventing repetitive injury and limiting chronic morbidity. It has potentially huge implications in returning to activity or work. In the athletic population, there are guidelines for return to play, and which includes not just their subjective symptom resolution, but also a normal neurocognitive and neurologic exam with a graduated return to activity. It's equally important to apply similar guidelines to populations concussed from recreational sports, motor vehicle accidents, work-related injuries, and other trauma. The International Consensus Statement from the 4th International Conference for Concussion recommends that all aspects of concussion be evaluated, including dizziness and balance problems. The new consensus statement from 2016 International Conference recommends a detailed neurologic assessment, which includes a thorough assessment of mental status, cognitive functioning, sleep-wake disturbance, ocular function, vestibular, gait, and balance. The 4 most common vestibular issues are BPPV, balance, BOR, and vision motion sensitivity. So we'll look at each of these. Balance. There are different ways to identify balance deficits. The simplest way will be through self-reporting symptom checklists, but these are not very reliable. Clinically, there are low-tech and high-tech options like the Biodex. Each have their respective advantages and limitations, reliability, cost, ease of time, ease of use, time to perform, training required to administer them, things like that. The most common test currently in use is the Balanced Error Scoring System, or the BESS. It was designed specifically for concussed athletes. Concussed individuals may not readily show balance deficits with straightforward tasks like just walking in the hallway. These individuals often have sensory organization difficulties. The BESS uses 6 positions, and it has been in the picture on the bottom. The 3 stance positions are with eyes closed on a foam surface. The BESS has been shown that balance can be impaired for several days following a concussion. Other tests that we can use are the Dynamic Gait Index and the Timed Up and Go to assess ambulatory falls risk. These and the chair sit to stand tests are quick and easy to use in the hospital setting. Visual motion sensitivity is also known as space and motion discomfort, visual vertigo, optokinetic hypersensitivity. Basically, it's just a heightened awareness of normal vision motion. So crowded places like supermarket aisles, school hallways, and tunnels will trigger symptoms of dizziness. BPPV is movement-specific dizziness. It typically causes a sensation of vertigo or spinning. Screening for BPPV is very easy with a couple of simple questions. Are you dizzy getting out of bed? Are you dizzy rolling in bed? If the answer is yes, this is highly predictive of BPPV. And in the 5-item subscale of the dizziness handicap inventory, you add 3 more questions. Are you dizzy looking up? Dizzy bending? Dizzy with quick head movements? If the answer to any of these or all of these is yes, you want to follow up with a Dix-Hallpike maneuver, or you refer your patients out. Normal VOR, vestibular ocular reflex, is the ability to focus while you're moving your head. If you are unable to focus or become dizzy when you're trying to focus, you have a VOR impairment. Vestibular and oculomotor screening. What is it? It's known as VOMS. It's a brief 5-minute clinical screening tool that's designed to identify additional vestibular and oculomotor impairments and symptoms following a concussion. It was developed by clinicians at the University of Pittsburgh Medical Center for use on subjects between the ages of 9 and 40, and it's meant to be used in conjunction with neurocognitive testing, balance testing, cervical and exertional testing in order to provide a more complete clinical picture. Baseline symptoms, headache, dizziness, nausea, and fogginess are recorded on a scale of 0 to 10. The screen has 5 domains, each assessed via patient report of symptom provocation. Smooth pursuits test the ability to follow a slowly moving target, so you have them track your finger side to side, up and down. Horizontal and vertical saccades test the ability of the eyes to move quickly between targets. So you hold your fingers apart, say 3 feet, and have them track you with their eyes side to side or quick up and down. Convergence measures the ability to view a near target without double vision. So you're holding your finger out and gradually bringing it in, and measure the distance at which they are symptomatic or start to have double vision. VOR tests the ability to stabilize vision on a target as the head moves side to side. And vision motion sensitivity can be tested by moving the head and the target, in this case a finger, side to side. So this is a picture of the VOMS scale. It's very quick. It just takes a couple minutes. I use this frequently in the trauma setting. Interpreting VOMS. So what does it tell us? Well, the control subjects report few symptoms following VOMS testing and have normal near-point convergence distances. With a near-point convergence distance of more than 5 centimeters, there is a 35% increase in the probability of identifying a concussion. Symptom scores greater than 2 on any VOMS item represents a 50% increase in the probability of identifying a concussion. So, You want to use symptom scores more than 2 and near point convergence more than 5 centimeters as clinically useful cutoffs. Also, of the 5 domains on the screen, a symptom provocation on 3 items, VOR, motion sensitivity, and convergence, resulted in an 89% accuracy in identifying patients with concussion. When VOR and VMS are positive, you want to refer to a qualified vestibular physical therapist for further assessment and management. For convergence insufficiency, pursuit, and saccade abnormalities, refer to either a vestibular PT or a vision specialist to evaluate and treat. So, in conclusion, concussion is a mild traumatic brain injury. It's highly prevalent, results in functional and metabolic brain impairment. Concussions are characterized by diverse symptoms and functional impairments resulting in different clinical profiles and recovery trajectories. It commonly affects balance, vestibular, and visual motor systems. So appropriate screening of balanced vestibular and vestibular ocular control should be incorporated into concussion management and assessment. Serious consequences may result from mismanaging concussions, so early identification and referral are critical for optimal management. Currently, no specific test exists for diagnosing a concussion. Concussion is a clinical diagnosis. A comprehensive, multi-domain clinical evaluation is necessary for diagnosing the different clinical profiles. A multidisciplinary team offers the most comprehensive approach to treatment and recovery. Active rehabilitation is initiated early, and that may improve recovery more than just rest alone. Conservative management via non-medication strategies is often effective in addressing common symptoms. Targeting active treatments to clinical profiles may improve recovery trajectories. Medications may be considered when behavioral strategies are inadequate. There is no FDA-approved medication for concussion. The medications are symptom-driven. The VOMS, it's a complementary tool that we just looked at to assess balance, neurocognitive, to assess vestibular ocular motor deficits, and it should be used in conjunction with balance assessment, neurocognitive testing, and symptom inventory. Initial research supports the utility of the VOMS as a brief vestibular ocular motor screen following concussion. In the acute setting, it may help guide early identification, referral, and treatment. In the hospital, using a multidisciplinary screening process can help triage our concussed patients with a faster referral for comprehensive assessment and intervention, and this can enhance patient care and satisfaction. Thank you. Questions? Questions? Everybody good? Okay.
Thank you very much. Anybody have any questions for her? Everybody dizzy? Okay, good. All right. So make sure you pick up your certificate on your way out. And if you are watching online, make sure you email me for your quiz. Thank you very much.
Before you go.
Yes, sir.
Before you guys go, anybody here have a participated?